then I will get started. So I'm gonna, like Dr. Salway mentioned, talk about geographic access to gender-affirming care. I'm gonna focus a good bit on things that have already been published or in the pipeline, and then toward the end, I'm gonna talk about a theory for access and some new data that's very, very, very new. So hopefully we can keep that between us. Okay, so initially, my research question when approaching this body of work was how geographically accessible is transgender healthcare in the US specifically? And I very rapidly found out that you can't begin to answer that question quantitatively, especially without first answering two other questions. Where exactly is trans-specific medical care available? And how many trans people are there who may or may not want to access said care? So we might think of it pretty typically in terms of supply and demand, but I tend to shy away from the more economic models. So I'm going to take each of these questions in turn, and they're going to sort of each be their own separate studies, but they kind of scaffold, and I will wrap up that section by pointing to the new data and to the theory for access. So this is as close as you're getting to a sort of roadmap for what I'm about to get into. So to start, where is trans-specific healthcare available? And again, specifically in the US. So why do we even need something like a spatial database? Well, trans healthcare isn't included in government data repositories, probably anywhere, or at least if it is included, it's not necessarily specified as surveying trans clientele. And we know from existing research on health information seeking that it's actually a process by which people create community and people build community out of trying to find information on where to access care and trying to find reliable information about gender affirming care more broadly. In a very, very, very recent paper of mine with my postdoc mentors and colleagues, Doctors Christy Gamrell and Oliver Hameson, just went live actually today. And we looked at creators of trans technologies that were designed to help proliferate access to care and access to health information. And I see this first study as sort of heeding the call from Jack King to queer GIS or geographic information science with good enough GIS. So I set about making a GAHT or gender affirming hormone therapy provider database. I pulled from existing spatially enabled databases as well as some tabular databases. So by spatially enabled, I basically just mean either web maps, Google My Maps, or things like that that are client facing where people go to find providers in their area. That resulted in a huge number. I deduplicated them, and then I went about verifying them manually. And by verifying, I mean I confirmed that they actually advertise that they do the specific kind of medical care for trans people. And in that process, I necessarily found further individual clinics and specific healthcare facilities. And I also found further local or standalone resources like, you know, the PDF that circulates among the community or the website or blog that no longer gets updated, but is still archived somewhere that people use to be able to find clinicians. And that final database number resulted in 913 unique healthcare facilities. That's important to remember, unique facilities, so locations, not necessarily providers. So I wanted to test how effective the database actually was in covering all the possibilities of where people might be accessing care. So I turned to the 2015 version. There's now a 2022 version that we're starting to see some initial results and executive reports come out of, but I used the 2015 US Transgender Survey, which was at the time the largest of its kind to have an exclusively trans set of respondents. And it claims to have surveyed about 1.86% of all trans people in the US. And that is a little bookmark for us to return to in the next study. So I pared it down to just those who answered a specific question about how far they traveled to access a trans-specific healthcare provider. And then only those that were in the contiguous US, Alaska, and Hawaii, just because they also have a specific relationship to federal mandates around healthcare, where Puerto Rico, Guam, Samoa, military bases, et cetera, have their own separate sort of system. So that was why the exclusion. And I had a subsample of 14,409. This is where it might be a little convoluted for folks who aren't familiar with geographic methods, but I will break it down. In the USGS, they were asked to report how far they traveled. And you can see those categories in the far left column of this table, under 10 miles up to over 100 miles broken down in between. And then the total from my subsample that reported each travel distance is there in the next column to the right. And then this third column, the total number who may have accessed providers not included in the database, was something I used by essentially a proximity analysis. So say somebody said they traveled between 10 and 25 miles to access their trans-Pacific clinician, then I could use their zip code that they reported where they reside, create a buffer of 25 miles. And then if I found a provider from my database that fell within that 25-mile buffer, then that may not be the actual facility that they went to. But if I don't find one, then that means they are definitely accessing a healthcare facility that I did not have in my database. Hopefully that makes sense. If it doesn't, this paper's been published and I probably explain it a bit better at further link. And so you can also see in the far right column, the percent of each category that it was that had people who may have accessed providers not included in the database. So it kind of stands to reason that folks who reported traveling a shorter distance were a little bit more likely to access a provider I didn't know about. But it does tend to decrease the further away people reported having to travel to access care. But when we collate as a total, it's about 7.51% of respondents to the USTS who likely accessed a provider that I did not have in my database and was unaware of. And in Canada, that's an A+. But it's definitely an A even by the American standard of a 93%. So I gave myself an A and published a paper about it. So to show you what that looks like mapped in terms of its comprehensiveness by state, the lighter colors here are the places where the database performed especially well. So meaning there were fewer and fewer people who were likely to have been accessing a provider that I did not have in the database. So those were the folks who said, I only traveled 10 miles and in my database, I found no provider within 10 miles of where they said they lived. If you are at all familiar with the states, then this map might look like it's got some quirks to it, some idiosyncrasies. So I'll highlight some of those. Some of it's very expected, as you might imagine. Wyoming, South Dakota, and West Virginia stand out as especially less comprehensive. But I take that as actually probably a net positive. So that means that people are better at getting care that they need in those areas at the time that I did this research than I was able to account for. So especially in this legislative context where people are harassing clinicians that provide this kind of care, it might be a good thing that there are sort of these networks where people are able to get the care they need without clinicians having to advertise in public facing ways that might, expose them to violence and harassment. But it could also present some limitations to people's access. North Carolina, my home state, I have to shout out because it stands out in the Southeast as a place where the database performed especially well. That could easily be a function of me just knowing North Carolina better. And so I did a better job of finding facilities there. But interestingly, Texas was also especially comprehensive. And keep that in mind because one of my later studies focuses on Texas. So if you'd like to see more from this, the method for the database construction and results are published in Social Science and Medicine. This one is not open access. I apologize. Did not have funding at the time. But this QR code also takes you to the database, which is available on GitHub. Again, it's not a client-facing tool. It's designed for research, so may or may not be of interest to many of you. But there are much better resources for folks who are just looking to access care than this. This is a collated spatial database, mostly for research. So now that we've sort of established where care is provided, we can turn to asking how many trans people there actually are in the US. And again, to set it up, I want to talk about the stakes. Excuse me. Had a little bit of a lapse, so I'm getting trigger happy with my next key. So these are some pieces that I really, really like, especially from recent years. Hale Thompson and Lisa King have a very Foucauldian analysis of the biopower of data collection and also the political economy of funding that might be fostering this, shall we say, outsized estimate of things like the prevalence of HIV among trans women globally and things like that. Megan Rower, in the same issue that the above piece appears in Transgender Studies Quarterly called Making Transgender Count, Rower argues for an ethics of undercounting as a way to eschew the colonial imposition of transgender as a category onto all gender nonconforming people's experiences, both in Anglophone global North context where it might apply, but also to autochthonous systems of sex and gender that predate colonial contact. Ellett and myself, shout out to Dr. Ellett, about to be Dr. Have argued that existing estimates might actually be undercounts due to a lack of community buy-in and acceptability, especially of data collection protocols. So really how we ask who is trans and why we're asking. And then a recent book that's really great, it's been staying on my desk because I keep revisiting it, by Kevin Gayan, called Queer Data. He argues for queering data by ensuring that we as LGBT people are counted so that we can count, and wrestling with the ambivalence of what it means to collect data on queer and trans people. And now that I put it on a slide, I have to be accountable to all 86 people that are here. I've begun work on a book on this topic as well. So if I were to ask you, you can think to yourself, I'm not sure if the chat functions, it doesn't need to, because I probably wouldn't even have the space to read it. But if I were to ask you, what % of the population in the US do you think is transgender? Think that number to yourself. And I'll give you a second to arrive at it. And I've heard all kinds of them. So if you turn out to be wrong, that's fine. If you read trans health literature based in the US, you will often see this sort of throat clearing remark at the very beginning of each paper. There are an estimated 1.4 million transgender adults in the United States. So the most frequently cited figure is about 0.6% of the US population. It may or may not surprise you to know that there is only a single source for this specific estimate. And it holds up what in my more hypercritical moments, I refer to as a house of cards around trans demographics. It's a 2016 study from the Williams Institute, which also very prestigious. They do a lot of great work, but most of their reports are not actually peer reviewed. They're done in-house for policy facing work. It was derived from the behavioral risk factor surveillance system, so one single data source. And they did some good old fashioned ordinary least squares regression, even though at the years that they used the data, there were only 22 out of 50 states plus Washington, DC that actually used an optional protocol for ascertaining sexual orientation and gender identity. But this figure circulates widely in the health and social scientific literature. So I wanted to consider what are the possible alternatives, because we're definitely not going to see trans people counted in the census enumeration process in the US, at least not anytime soon, even though Canada has made that step in its most recent census. I don't think we're going to see that in the States for a long time. So instead, I turned to a different source, the Household Pulse Survey, which is actually run by the Census Bureau instead of the Center for Disease Control and Prevention. And it has a totally different sampling methodology. It's internet-based random household sampling. It's also national and by state, but it also includes metropolitan statistical areas, so something to keep in mind. And instead of having an optional module for ascertaining sexual orientation and gender identity, it has a mandatory and a two-step protocol. Now, we could definitely have a discussion about whether or not the two-step protocol is the ideal, but it is definitely a method, and it allows us to do two different versions of ascertaining who might be trans in a data set. So I collated 7 years of annual data from Birthfest from 2014 to 2020 and used 7 waves just for parallelism, not for anything else really, of the household pulse survey. And it should be noted that, again, neither were designed to derive population estimates. However, since one widely circulating population estimate has already been derived from one source, I thought it would be worth comparing them. So to unpack the BRFIS, that behavioral risk factor surveillance system, this map in the bottom left is just the number of years in that 7-year collation where the sexual orientation and gender identity optional protocol was used by each state. So the darker the color, the more frequently they actually used that optional protocol. You'll also see a good handful of states, the Dakotas, Oregon, some up in New England actually, that have hatch marks because they've never used this protocol. So we don't actually have truly nationally representative data with the SOGI protocol from Birthfest, even though we have some places where they've used it every year, like Hawaii, Minnesota, Wisconsin, Virginia, et cetera. And then when you look at a change over time in terms of the overall estimate for the total population that you can get from combining all of the states in each year that did use that SOGI protocol. On the top, we see a weighted percentage, the pink line, and on the bottom, we see the teal one, it's an unweighted one. There is, we could argue, a vaguely linear trend upward from year to year, or an increase in the number of people that are identifying or are being identified as trans from this data source. So then when we actually compare that to the results from the household pulse survey, we can see a pretty stark difference. So to give you the clues on how to read these, if you look really closely at the legends for each of these maps, the color schemes are the same. So the lightest color is up to 0.5% of the total population, so that being the highest population estimate. The next goes up to 0.75%, then 1%, 1.25, up to 1.5. So the colors are the exact same, which is why on the left there are a lot of much lighter colors, and there's none of the darkest color. And on the right, overall, it's much darker. This is just to give you a sort of visual contrast. And we'll count that as your intro to cartography for the day if you're not used to reading maps. So initially, it's pretty clear that there's a stark difference, probably nationally, but definitely state by state. So I wanted to quantify that a little more clearly. I censored the states from Birthfest from which I have no data, so that we're only comparing data to data. And when you do a percent change in rates of trans identification for each state, there's some very interesting dynamics that reveal itself. So Texas, Wyoming, and Nevada have household pulse rates that are more than 2 times the rates of trans identification in Birthfest. So the estimate of the percent of the population that can be identified as trans from these data sources is more than 2 times greater in these states, according to the newer and differently assessed survey than the Birthfest. So Texas, Wyoming, and Nevada in these darker colors. Interestingly, North Carolina is the only state with higher rates of trans identification in the Birthfest when compared to the household pulse. I don't know why. I can't tell you, but I can offer some thoughts on why the two compare in this way. And just to give you that satisfying little number that everybody wants to have, when we do amalgamate nationally, the household pulse survey estimate is 0.95% of US Americans identify as transgender. According to these 7 waves, the household pulse survey continued for a while after this. So I want to come back to this chart and dive into what are the key places where these 2 surveys differ and how might they be affecting the results that we saw. So chief among them, in my opinion, is the sampling method. Now, I don't know about you, and thankfully I think that it's not quite as big of a problem yet in Canada, but I still have an American number. I get spam calls constantly. And even before I got spam calls constantly, I hated talking on the phone. So if you were to tell me, even if I were to expect it, even if I had an appointment that the government was going to call me and ask me a bunch of questions about my health and my identity one day, I would not answer. That's just me. Maybe y'all would. Maybe you're the type that you get a call from a block number and you're like, ooh, this is exciting. I want to know who it is. But that's essentially the method that's treated as the gold standard for random sampling is random digit dialing. But the household pulse survey uses a totally different one. It's internet-based and it's still random household sampling. So the invitations go out based on a randomized household sampling that's spatially specific. The BRFIS is administered by state public health departments. So it's kind of up to them how they do their data collection each time, which is why they can opt in or out of certain modules. But the household pulse was done nationally by the Federal Census Bureau. Additionally, as I stated in the beginning, the BRFIS has this optional module, which is why there's still huge gaps in places where we have no data. Compared to the household pulse, instead of there being, what is your sex? And then later there's questions, maybe do you happen to be trans perchance? Everybody is asked, what was your assigned sex at birth? What is your current gender identity? And that's how they ascertain sex and gender for the survey, at least starting with phase 3.2 in 2021. Prior to that, all the previous waves had a different protocol. But then it became mandatory, and that's how all sex and gender data was ascertained. So I really think that this is one of the keys, is that if we're going to look at these surveillance systems, which is essentially what they both are, that we need to be careful about extrapolating from them, and we need to think critically about what are the means by which we're going to derive demographic estimates about especially smaller populations, marginalized populations, people that might not have the same level of trust in government entities, all sorts of reasons why people might be more or less participatory in different formats. It's all worth considering. This paper is under review. I've had some trouble placing it, to be honest. So hopefully for any trainees, grad students, folks like that are also having trouble like that because you feel like maybe you're innovating and the peer review process is not going the way you want. It happens to all of us. So that's how I ended up comparing these two sources and ended up with a slightly different estimate of the size of the trans population. So with those in hand, we can now finally turn to how geographically accessible is trans-specific healthcare. So in this, I turned to Texas, which you'll remember was especially comprehensive from my database of GAHT providers. It's also the second largest state in terms of population and land mass, and it has a significant swath of the entire state that is considered rural. And every county, every single one, has at least one medically underserved area. This is a designation according to the Health Resources and Services Administration that basically we could use as a stand-in for this might be a care desert in terms of primary care. So because the household pulse included state, but also metropolitan statistical area data for the 15 largest MSAs, I was able to have Dallas, Fort Worth, Arlington, and Houston, the Woodland Sugar Land as separate with their own separate rates of identification as trans from the overall state. And I used those estimates to get tract level population estimates for how many trans people there might be in given census tracts from using the Census 2020 data. And obviously this is couched in the context of the socio-legal and politically, culturally, all sorts of repressive environments for trans people in Texas. And this little first map just shows you the estimated trans population. And obviously, this is not population density, so it's just giving us count, which will be important. And here was my method for measuring geographic accessibility. If you look at this and your eyes cross, that's fine. You don't need to know all of these statistical steps. I will highlight what each of them are. So the first is a selection weight, which basically just means When I calculate drive time windows, those floating catchment areas, it's possible that you'll have more than one facility that's within the drive time to the census tract that I'm analyzing. Cool. So what we do is weigh the likelihood of that selection based on the distance. So say you have 2 that are within 15 minutes drive, 3 that are between 15 and 30 minutes drive, so on and so forth. They're all going to be weighed differently based on that distance. So each individual relationship between population in the census tract and healthcare facility has a different weight. And then you calculate a physician to population ratio. I like to refer to it as a clinician population ratio because, as we know, there's actually quite a few nurse practitioners, physician's assistants in the States, et cetera, DOs that do this kind of care. So it isn't just MDs, but this is how it was designed. And so this is basically our supply demand ratio. So how many providers are there in a given area per potential population demand? And then the final one is an actual computed accessibility index, where we are able to quantify how geographically accessible everything is based on the selection weights, the physician population ratio, and combining that information. Okay, so drum roll. What does that actually look like? It looks like this. And the cutoffs here, I'm happy to spend more time unpacking if you're interested in them. They have to do with whether or not we might consider trans care to fall under a specific specialty like endocrinology, or if we would consider it primary care. If you're curious about those cutoffs, feel free to ask me in the Q&A. But suffice it to say that I just did 3 classes for this. So the darker the color, the better the spatial access to care in that area. So if you're looking at this and you're like, I actually don't see any discernible patterns, that's because there are none. And you would be right, and you haven't missed anything. So I started to look to other potential geographic variables that might explain this. And it stood to reason, if the literature is correct, that we can assume that urban trans communities are going to have better access to care. So I looked at urbanicity. But then we can see from this bivariate map, which they're my favorite, love anything by, but to give you a sense of what these are like, if you look to the legend in the bottom left, low access is essentially the lighter colors. So the really light orange or the teal. High access to gender affirming care is going to be the dark orange or the brown. So I want to call your attention to the Dallas and the Houston areas where we see huge splotches of brown and teal. So it's all urban, which is why it's blue and brown, but there are lots of parts that have poor access to gender affirming hormone therapy and lots of parts that have really good access. So it seems that urbanicity is not the only way that we could explain this either. So then I started to look at medically underserved area status. So again, our sort of stand-in, our proxy measure for whether or not an area is a care desert for primary care for the general population. So again, another bivariate map. This is a running theme. You will become experts at reading them by the end of this. The low access to trans-specific care is the light gray and the light blue. High access is the red and the brown. So now we can kind of see a bit of a pattern emerging. If we look within Dallas and Houston, we can see where kind of these lines of demarcation are. There are some places in Dallas where we see medically underserved, but strong spatial access to gender affirming care. That's what those reds are. We also see, of course, some places that are medically underserved and have poor access to gender affirming care. Those are the grays. But we also see some where there's pretty poor access to trans care that are not otherwise considered medically underserved for the general population, those teals. And there's actually quite a lot of them in there. So now I was like, okay, urbanicity might not explain it, rurality might not explain it, but there is something about this relationship between medically underserved areas, according to HRSA, and gender affirming hormone therapy access. So being the good geographic information scientist I am, I go to my good old hotspot analysis. Happy to unpack with y'all in the Q&A what specific measures of spatial autocorrelation I used for this. Folks who use Esri products will recognize this as one of the suite of hotspot analyses, but I was very specific about which ones I used, and happy to talk about that as well from the paper, which is published. So cold spots are places where it's especially poor access to trans care, and hotspots are places where it's especially good compared to its neighbors. So all the blues are cold, all the reds are hot. And you might be looking at this and thinking, why is Austin such a cold spot? We will talk about it. And then we can also look at our zoom ins on Dallas and Houston and see that Weatherford is an especially strong area for access to trans care, while the Fort Worth, even into Waxahachie area, is especially poor access. So there's something going on. So then one final bivariate map, I compared that hotspot, which tells us whether or not something is spatially statistically significant, essentially, and compared it to medically underserved areas. So if it's dark red or dark blue, it's not medically underserved for the general population. So it's one of few areas that is not considered to be a care desert for primary care. The lighter areas are medically underserved. So we can see that there are some light reds, meaning that they are a hotspot for good access to trans care, but they are medically underserved for primary care for the general population. And we can see some of those outside Sugar Land and Rosenberg in the Houston area. We can see some of them in Weatherford. We can see a lot outside San Antonio. And then sort of along the border areas, even especially with Mexico and like Juarez, for example. But then we also can see some places that are enjoying especially good access to care overall, those dark blues that are enjoying good care access for primary care, but are especially poor for access to gender affirming care. And that would be our Fort Worth, our Austin areas, those dark blues. So lots to unpack here. So to talk about some conclusions, just briefly, on my slide, okay, they are advancing. So we had some places that were low access for trans care and also medically underserved for primary care. And those are places where I'll talk about in a moment, we could have very specific kinds of interventions that might be really useful for improving care for everybody. But we also can see some areas in San Antonio and Houston, among others, where primary care access was low, but gender affirming hormone therapy access was higher compared to the rest of the state. That's in the light reds. So this tells me that patterns of geographic access to gender affirming hormone therapy likely diverge from general patterns of geographic access, not only in Texas, but perhaps elsewhere as well. So my recommendations from this paper, which again is available open access, you can see a screenshot of it on the right, is that we can do some service planning work to address both the primary care shortages and incorporate maybe trans competency training and trans-specific medical training to be able to, I wish I had a non-violent alternative to kill two birds with one stone, but to proliferate healthcare for everybody. And this kind of intervention could be useful anywhere, including BC, where we also face a different kind of primary care access issue. These results also indicate that a spatially explicit methodology is needed to truly understand access to different kinds of healthcare. And I'll talk, if I have time, at the end a bit more about access as well. So those are the results from this. I want to briefly talk about some preliminary results from new work, where instead of relying on population modeling, I've gathered primary data. So again, very new, but happy to talk about it. As part of my postdoc at Michigan with doctors Christy Gammerl and Oliver Hameson, we did a survey, an online survey of trans adults, and it compared gender-affirming hormone therapy, gender-affirming surgery, and primary care. And of course, the hypothesis was that people might travel further for gender-affirming care of any kind than they do for primary care if they don't see the same clinicians for both. But there's also self-reported access to specific clinicians with travel time, and also how people source information. So there's quite a bit there that I'm really excited about. And there were some new research questions, but chief among them is this one. Do trans people report traveling further to access gender-affirming hormone therapy than their nearest facility? So in combining my existing database that you saw in the first study and the self-reported facilities from this survey, so I asked people where they went for care, after deduplicating them, there's 1,134 unique facilities, and there's actually very little overlap between the two, which was really interesting and useful for me. So I'm able to compute service areas and derive nearest and next nearest facilities. So I've begun to do some of that, but just to give you the basics, in terms of self-reported travel time, I asked in minutes instead of miles because we're better at time than we are distance, although arguably we're not great at either when it comes to estimating. But we can see that a vast majority traveled less than an hour to access their GAHT provider. And a good plurality, a good chunk of them traveled less than half an hour. There were a small handful that had to travel more than 2 hours to access care. And I say had to, but that doesn't necessarily mean have to, which is the question I was investigating. So let's say this is where somebody reported living. And let's say there's a provider here and one here. The reason I'm going to do nearest and next nearest as well as service areas is because I could derive a service area like I did in the last study that we talked about in Texas, and I might find this specific clinic. And I know that that one's going to be the nearest. But the next nearest is just outside of that distance. So if I can determine whether or not they traveled to either the nearest or next nearest, then that can account for some of that variation in our ability to estimate distance and time. So in posing the question more directly to the data and asking whether trans people seek care at their nearest facility, I did some computation of service area based on their reported travel time. And this is super preliminary. And the dots you're seeing is not actually where people live, so don't panic. This has been geomasked. The dots are where clinics are, according to which source. And almost none, 2 out of 423 reported accessing the facility that was the nearest or next nearest in my initial analysis. I'm going to reduce some of that because I'm suspicious that it's so low, but initially it was only 2. It could be explained by minute differences in distance in places where there's a lot of facilities, or it could be transportation method, all sorts of things. But if respondents were not traveling to either their nearest or next nearest facility, then we know geographic availability was not the primary driver for their provider choice. And interestingly, even though I say this all the time that we can't control for geography, when we do something like this as a spatially explicit analysis, we kind of have landed on a way to control for geography as a predictor of access, which means that there's something else that's driving why people are accessing the clinics that they access. So in some initial service area results, what I basically do is see how many healthcare facilities from my combined database fall within these drive time service areas. And there's nowhere where there's no healthcare facilities, which is great for the comprehensiveness of the database. But we do see some significant variation. So what that means is if almost nobody is traveling to the nearest or the next nearest facility, but according to their travel time, there's anywhere from 1 to as many as 17 or 39 or 55 or 79 different unique healthcare facilities that they could access, then it's not necessarily that they're spoiled for choice. I don't think we should have to travel 2 hours to see a doctor, but that's just me. And I live in a city for that reason. But it does mean that there has to be something else besides where care is being provided that drives why they're seeing the clinicians that they see. So as I continue to work through this stuff, I have a bunch of other questions I want to ask, obviously. And this is based off, like I mentioned, recent work with the same team. And we just had something that came out that's qualitative, looking at not the access side or the care seeking side, but the creators of trans technology that made information about providers and about healthcare generally available. And I really like the paper. It's been a while since I've done some more qual stuff, so this was really fun. It's also open access and just came out. So inspired by this kind of work, we incorporated questions into the survey about what people do when they have questions about their care. Do they ask a trusted friend? Do they ask their healthcare provider? Do they go on the internet? Do they get on WebMD, or do they go to Reddit? Are they on a Discord server for people that are also on hormones? Like, what are their methods for sourcing information? And I'd like to look more into that to see whether or not those could be potential drivers for the access decisions that people make. I'm very close to out of time, so I likely don't have much time to actually talk about theorizing access. So cover your eyes if you must. I don't want to give you whiplash. I'm going to skip through some slides talking about human rights law and all sorts of things, and instead leave you with this in particular, because I do have a chapter coming out in an edited volume that might be of interest to folks that I call Toward a Transdisciplinary Theory of Access that bridges medical geography, especially its methods, intersectionality theories, and the human right to health. I'm happy to share this with anybody that's interested in it, but yeah. So with that, I will stop and say thanks especially again to Dr. Gamrell, Dr. Hameson, Ini Ubong at the University of Michigan, my RA here at UBC Geography, Ophelia Tong, and of course, countless other people that have been super supportive of my work. There's my email if you have questions and you'd like to reach out to me directly, and I'm happy to take any questions.
First, just a clarification question about the second to last study where you were showing the time people were reporting to travel. That was, I believe that was national. Someone had asked what state that was regarding, but I think that study included all of the US. Is that correct?
If it was my new survey data, it's national to the US. If it was the super quantitative population modeling one, it was Texas.
Right.
The other two were either the US Trans Survey, which is national, or two national health surveillance systems.
Great, thank you. Yeah, I think this was the one after the Texas study, so I think it was national. So a couple of people have asked, first of all, lots of appreciation and praise for your work. Congratulations on a very compelling presentation, Dr. Everhart. A couple of people have asked, since we have different data and in some cases maybe better data, like some moves towards better gender inclusive data in the Canadian census. And now that you are here in BC, people are wanting to hear, what do you have in mind for expanding your work and methods to Canadian data?
Yeah, so that's one of the things that I'm trying to work on now. And what I'd like to do is more primary data collection with Canadian trans folks to understand whether or not there are some systemic factors that make patterns of access different. So my working idea for that is sort of just repeating the survey in Canada and really trying to grow my networks first to make sure that the recruitment is solid. Because I think that what will be interesting is if the data essentially matches in terms of the questions asked, but the results differ significantly, then we can necessarily discern that that means there's something systemic about the health and the legal system in Canada that might make those patterns of access look different. There's also definitely some demographic and geographic differences. So population density and just how populous Canada is overall is quite different from the States. The figure I often use, which every time I say it, I'm like, it sounds wrong. But the total Canadian population is roughly double the size of the New York City metropolitan area, just to put it into perspective. So there's necessarily going to be some different issues in terms of demographic spread over space and place. But I'm really interested in doing that. I'm also new faculty and just like, oh, I'm going to have a new paper with this survey out before I even start, and had all these big ideas. And instead, I've been like, panicking, teaching, moving to a new country, all of that. I'd like to get funding to be able to do it, but it's competitive everywhere. So
thanks. Yeah, I think people across the board are looking forward to seeing with time how those methods and studies roll out in Canada. Kai has asked, do you think the increased use of telehealth since 2020 has changed the significance or importance of geography for healthcare access for trans folks?
Yes and no. So sorry, I just talked so much that my lips feel so chapped.
That
Yes
should only
and
take
no.
care.
So I actually just spoke with a reporter at CBC about this, who's been looking into the Foria Clinic, who was providing telehealth services paid for by the provincial government in Ontario, up until they stopped covering that after claiming that the COVID-19 pandemic is over. And so apparently very reluctantly, they've gone private. I think I'm very suspicious of anything that treats technology as this like utopic tool that will fix all problems. There are definitely still some things that cannot be done by telehealth. So for example, there are things that we do know to watch out for when taking exogenous hormones. So you need to have your liver function monitored. You're going to have routine blood work. You can't do those things over telehealth. And you certainly can't do them with just, a finger prick the way that I was really hoping that that one woman who like lied to everybody about it with her tech company, I was hoping she'd figure it out because I hate blood work. But in terms of just face-to-face provider interaction, being able to call in prescriptions, it's definitely an option. But the other thing is that we also know there are issues in access to the internet and other telecommunications that are affecting folks in more rural areas or in places that are being differently affected by climate change, escalating natural hazards, things like that, that can easily knock out access. So if the idea is that telehealth can solve a quote unquote rural disparity in access to care, I don't think it's that cut and dry. I think it can make things better for a certain class of people who are tech savvy, who know how to navigate the internet, who have consistent access, but not necessarily for everybody. I'll leave it at that because I have lots of feelings about telehealth.
Okay, no, that's really helpful. Thanks. So, okay, a few more questions. First, there's a couple of folks in the chat who have suggested local public health or community groups that I think would be really interested in your work. For example, the Ministry of Health, the BC CDC, the Community-Based Research Center. So I'm assuming it's okay if I direct them to email you and make those connections, Avery?
I would love that. I would love that.
Okay, great. So thanks to our attendees for making those really helpful connections across our network. So two more questions have come in through the Q&A. First, thank you. This work is so cool. In all caps, I agree. I know a lot of people who access gender-affirming hormone therapy from their primary care providers who often don't advertise this service. So I'm sure that is and will be a challenge. Any thoughts on how this could be handled? I'm assuming like from a research perspective. Yeah, the two nearest neighbors methods make sense, but of course I would personally drive along and see a provider I am more comfortable with. So excited to hear your thoughts on that.
Yeah, so thank you for the question. Now we're kind of getting into method a little bit, which I always love talking about. So in my survey, that was something I accounted for. I asked, do you have the same primary care clinician that you see for gender-affirming hormone therapy? Which likely, I can't know, but likely explains why there's so little overlap between my existing database and the new slew of clinics that I found from the survey itself. Because there actually was a surprisingly high percentage of respondents who had the same clinician for both. And I also know that's how a lot of folks get started. If you happen to have a good relationship with your family doctor, your primary care clinician, then why not explore that with them as opposed to having to outsource things? And in Canada, there was this specific, I don't know what to call it, initiative that happened where such a bottleneck was happening around having to get, mental readiness assessments that eventually provincial and federal governments were starting to direct primary care providers to actually do this care for people. So this raises the other question of like, what is trans care? Is it a specialty? Should it be part of primary care? Should it be endocrinologists doing it? Should it be OB-GYNs doing it, et cetera? And the answer is yes, all of them. But in terms of methodologically, how I've handled that is it's also one of my sort of dichotomous outcomes that I'm controlling for in my existing analyses. because again, one of the hypotheses I'm testing is that people might travel further for primary care or further for gender affirming care than for primary care. And that was a really unexpected result to see such a high prevalence of that, that I'm looking forward to diving into it a bit more. And in terms of the nearest neighbors, you're actually pointing out why I'm doing it, which again, I had to rush a bit. So I should have, ideally spent a little bit more time to explain it. But the reason I am doing nearest and next nearest neighbors is similar to like my database construction, where I'm like, okay, if I find a facility, then that means my database is doing good. But if I don't find one in the area of how far you said you travel, then that means you're going to a provider I don't know about. This is similar, where if you report accessing a clinician who is neither your nearest nor your next nearest, then I know that you're not actually just going off of a function of who's the most readily available geographically. I say no, but I can, it's a conjecture. You might not know about those clinicians. That could definitely be a potential limitation. But the reason that I'm going with nearest and next nearest is specifically because of that, is that I know, again, from my own personal experience, that you'll see the provider that you're comfortable with, and that even as your life circumstances change, you're likely to stick with the same clinicians, even if you move. My provider in LA, actually had 2 different patients who flew in every 6 months from Brazil and Argentina after they left the country. So I know exactly how that goes, and I'm trying to account for it methodologically, but it's obviously going to be something I have to work through.
Thank you. That's really fascinating, and makes good sense. Okay, I'm going to squeeze in one last question, which is, are you able to track the folks who are accessing gender-affirming hormone therapy without clinical supervision? So through informal networks, DIY use, trades with friends. And in your study, are you able to account for insurance coverage as part of what's going on around why people might be traveling?
Yeah, so I'll start with insurance coverage. So that's part of my new intersectional human rights-based quantitative method that I'm looking at, is there's all these other factors that affect access beyond geography. And I think that, albeit imperfectly, we could quantify them. And it's driven by intersectionality in the sense that we know that the patient-clinician interaction is necessarily imbued with social power along lines of social difference. So Black women are not as often believed about the pain that they're in, and therefore not treated for said pain compared to their white counterparts. Trans people report higher rates overall, but again, trans people of color usually even higher rates of avoidance of care, denial of care, mistreatment, and accessing care. So in trying to, instead of drilling down to the individual where it can sometimes pathologize people's behavior and choices, I try to pathologize the system and the structure by looking at things like insurance. So how does insurance coverage in the States affect availability geographically, but also otherwise for different kinds of clinicians? I also look and beginning to look at the fee model. So there's fee for service model, et cetera. So it's something that I'm looking into, and I think we can quantify. It definitely does affect people's access. In terms of DIY, really quickly, 2 things. One, I don't know that we should track it. I think it kind of depends. So like, I did ask, and there's actually some qualitative write-in data that my colleague Ini Abasi-Ubong at Michigan is working with, where people were talking about that, to be like, well, I haven't seen this provider in a long time, but like, I cobbled together a network of people that I can rely on to have consistent access. And there has been some work on DIY use. And I think that's much more of a qualitative question. And in terms of where it's happening, that's even harder, because we have to assume that it's likely going to be less frequent than people following a more traditional model of just accessing a clinic and either paying out of pocket or using insurance or whatever it is. So I have looked into it, but the numbers are small enough, especially when I'm looking at a convenience sample and it's based on how well I can recruit people, as opposed to the alternative, which would be something like a health surveillance system, where I don't think we should be tracking that necessarily. But yeah, that's kind of the issue I'm running into with it.
Really fascinating. I can see so many ways in which your work is just going to continue to grow in across lots of different dimensions and intersections, and really excited to see what and how you'll bring these methods to the Canadian context. So thank you so much, Dr. Everhart. It was a thrill to hear about your work, and I think you've prompted a lot of great ideas and collaborations among our audience. There are a few questions we didn't get to, and we'll be sure to send them to you afterward. But we're at the top of the hour, so I want to say thank you. Please join me in a round of virtual applause for Dr. Everhart.